Welcome back to another special episode of Oncology for the Inquisitive Mind, featuring none other than Michael and his illustrious co-host, Dr. Josh Hurwitz, which I just called myself that because I felt like it. This is our day 3 capture of all the latest and greatest coming out of ESMO. There have been triumphs, heartbreaks, and everything in between. But Michael, thank you for sitting here next to me. How are you today?
I am excellent, Josh, as always. Thank you for that lovely introduction. And I think heartbreaking refers to our energy levels at this point because we have been quite literally almost swept off our feet at this conference.
Yeah, and I feel that the jet lag has not gotten that much better.
It's one of the many difficulties with travelling anywhere from Australia is it's at least 10, 15 hours, and to come to Barcelona, it's about 25, 30 hours flying.
But we do love Barcelona. Michael, you should hit the ground running because we've got quite an interesting trial in the urothelial carcinoma space. Very exciting area, bladder cancer these days. I feel last year and this year it's just kind of started to peak, and I'm looking forward to some more really interesting data coming out.
Absolutely. And this episode is going to be exclusively GU focused.
Oh yeah, I didn't even realize that, but I think that's what we saw.
That's the way the cookie crumbles, as it is.
Well done.
Thank you. So this first study is a study of Disitamab vedotin plus pembrolizumab in patients with urothelial cancer with HER2 expression. And right off the bat, they hooked me with this presentation, Josh, because they opened with this interesting factoid. 60 to 80% of patients with urothelial carcinoma have some measure of HER2 expression. I had no idea it was that high.
Yeah, and it's just HER2 expression isn't just an interesting target because it's everywhere.
It really is, and the combination of a HER2 or indeed a HER3 antibody with a cytotoxic payload is really proliferating in the anti-cancer space. You've got tons of drug companies that are putting tons of resources, money and research development into developing these drugs. So Disitamab vedotin is one such drug. It is an antibody-drug conjugate against HER2, and like most ADCs, it can induce immunogenic cell death and also has a bystander effect. Now, what was presented at ESMO was a small cohort of a safety run-in of a phase 2 study examining Disitamab vedotin plus pembrolizumab. Interestingly, they enrolled patients who were both HER2 positive, and that's by the standard cohort with an IHC of 3+, or an IHC of 2+ with a positive-ish or FISH, as well as patients who were HER2 low. So with some measure of positivity who didn't meet the criteria for HER2 positivity. The primary endpoint was overall response rate. 20 patients were enrolled in this safety run-in, and the confirmed overall response rate was 75%. And it doesn't take a mathematical genius for you to realize that that's 15 out of 20 patients. More interestingly, the radiological complete response rate was 35%, which is great in urothelial cancer. The HER2 positive overall response rate was 68%, but interestingly, the HER2 low overall response rate was 78%. So the degree of HER2 overexpression does not necessarily portend the degree of response, at least not in this very small cohort, which is both interesting and also good for the clinical applicability if Disitamab vedotin makes it past the phase 3 gauntlet. Treatment-related adverse events included diarrhea, fatigue, alopecia, and peripheral neuropathy, all stuff that we've seen with vedotin-related ADCs, most typically with enfortumab vedotin. There were no grade 5 events and no instances of interstitial lung disease, always a consideration with a HER2-directed ADC, as we saw with trastuzumab deruxtecan. 19 out of 20 patients did require a dose reduction, however, so the toxicity with Disitamab vedotin is not nothing, but the fact that you could get people on this and get them to the point where they had a good response is always good. So to conclude this very interesting study, there is a promising efficacy signal with Disitamab vedotin. Again, a very high proportion of patients with UC theoretically would benefit from this. So fresh off having EV shake up things, we might be seeing a future shake up for a significant proportion of patients with UC. There were no new safety signals identified in this safety run-in, and a phase 3 study is coming, which we look forward to with great interest.
It's just so crazy that bladder cancer is now becoming a crowded field.
Absolutely, and if you stay with us, there will be an even more impactful bladder study that was presented at the plenary later on day 3. that is Niagara, and it is very exciting. But you're absolutely right, Josh. Bladder, after being almost an orphan cancer with awful outcomes for so long, is becoming really, really crowded, and that's only a good thing.
Yeah, that's exactly right. Michael, I'll jump across also a bladder sub-study, I think you could say. And with all of these trials, everyone's looking for that golden biomarker. How can you predict a response for patients who have different expressions, different targets? Why does person A respond exceptionally well and person B not so much? And this is based on the EV302 study, which was the enfortumab vedotin and pembrolizumab study. This was the standing ovation last year. It was the first trial ever to best chemotherapy practice in the metastatic setting in the first line. So really exciting. Enfortumab vedotin targets the nectin-4 expression, and it's widely expressed in urothelial cancer. The question has been raised with this trial, what's the relationship? Does expression predict outcomes? And that was really the premise of this, I guess, sub-study or this biomarker program for EV302. They changed the way they sort of looked at this. They looked at sort of how heavily expressed the nectin-4 was, and they divided it as sort of low expression and high expression. So interesting, most patients were highly expressed with a median score of 275 out of 300, and 10% of patients had an expression of less than 150. So the majority of the biopsy samples submitted were of the primary disease site, meaning of the bladder itself rather than a distant metastatic site. The outcome when they were sort of looking at this showed that nectin-4 expression did not influence progression-free survival or overall survival. Low levels of nectin-4 still favored the EV-pembro subgroup in the progression-free survival and overall survival status. Looking at objective response rate, another really interesting question, and across the board, even with low levels, it outperformed chemotherapy. So there wasn't a subset of patients that responded better to classic chemotherapy versus the EV-pembro combination. So the outcome, what did this show us? It showed us that nectin-4 is highly expressed in almost all patients with urothelial cancer. This was the first comprehensive analysis of the nectin-4 in a randomized trial, and there was no concordant relationship found between expression and outcomes. And although this is like, all right, that's great, but it gives us some idea that nectin-4 is a good target irrespective of how much is expressed, but also you probably don't have to test for it, which is a nice thing.
Yeah, absolutely. And when we were listening to this presentation, which is obviously a very interesting sub-analysis of a pivotal trial, it got me comparing it to the approach that we take for gastric cancer and immunotherapy with the Checkmate 648 and 649, where you saw a significant difference in outcomes based on CPS. Obviously not the case here, but from a practical perspective, you don't end up withholding treatment based on that. And this is, the clinical application is going to be similar in that there's no real need to test for it, but it is nice to see that the outcomes aren't significantly affected.
That's it. That's really a great summary. Michael, what are we going to talk about next?
Well, we are barreling right along to the prostate aspect of our little summary here today, and we're going to look at two similar studies in different areas of prostate cancer. The first is the SPLASH study, and this is a study of lutetium PNT2002 or lutetium PSMA I&T, which is a PSMA targeted small molecule ligand. It seems to work from my understanding, in a very similar way to the more standard PSMA lutetium that will be used in Josh's study that he'll talk about in a moment, but the construction of the ligand appears slightly different. This was a phase 3 study of patients with prostate cancer, castration-resistant prostate cancer, who had progressed on a novel anti-androgen agent. Patients were randomized, interestingly, to lutetium PINT or to a second novel anti-androgen. They were randomized 2-1, and I thought the choice of comparator arm was interesting, Josh, given that the switch between two agents in the castration-resistant space is something that is definitely not done clinically, and I'm pretty sure there's evidence in the CARD study of cabazitaxel that switching novel anti-androgen agents isn't that effective.
Yeah, you're right. We don't do it in Australia. That's also based on our PBS, pharmaceutical benefits scheme, that there's not enough evidence to support really re-challenging with another androgen receptor signaling inhibitor. And I think there is some from potentially enzalutamide to abiraterone, or maybe the other way around. I can't remember, but it's not a lot of benefit.
Yeah, and that makes sense because those two drug classes do work in slightly different ways. So, in addition, taxanes were allowed, but only in the hormone-sensitive space, and this was they had to have completed their taxane chemotherapy more than 1 year prior to enrollment, so quite restrictive previous lines of therapy. The ligand was given 8 weekly for up to 4 cycles, and at a slightly lower dose than another study of the more classical lutetium PSMA, which was PSMA-4, and the reason I bring that up is in the discussion there was quite a lot of comparisons to the two studies. Crossover from the control arm was allowed, and in total, 77 out of 91 patients, or 84%, almost 85%, did receive the radioligand after progression on the second novel anti-androgen. The primary endpoint was radiographic progression-free survival, with secondary endpoints being overall response rate, duration of response, time to skeletal-related events, PSA response rate, biological progression-free survival, and overall survival. 412 patients were enrolled in the two arms. The radiographic progression-free survival was statistically significantly better in the radioligand arm, perhaps unsurprisingly. 9.5 compared to 6 months, with a hazard ratio of 0.71. The benefit was greater in patients who had a greater than median PSA, and Josh, I didn't quite actually catch what that value was. I think it was about 10 nanograms. Or thereabouts, but apologies if that's incorrect. The overall response rate likewise was superior in the radioligand group, 38 versus 12%. The median biological progression-free survival was 7 compared to 3.9 months, with a hazard ratio of 0.58, and this was statistically significant. And the health-related quality of life outcomes and the time to opioid consumption favour the radioligand as well. There was an interim overall survival analysis, which of course is immature, but this showed no difference at this point between the radioligand and a second anti-androgen agent. The adjusted analysis for crossover, which was an ad hoc analysis, it wasn't pre-planned, so you need to take it with a grain of salt, did favour the lutetium, however. In terms of safety, fatigue and dry mouth were the most common treatment-related adverse events with the radioligand, which is to be expected. That's very much in the wheelhouse of these agents. So as mentioned, there was a significant discussion and comparison after the presentation to PSMA-4, which was a similar study with very similar patients, but used the more typical 177 lutetium PSMA agent. It also used it at a higher dose, and this numerically at least appeared to convey a higher efficacy, with a hazard ratio of 0.46 compared to 0.71 in the area of radiological progression-free survival, with similar toxicities. So again, it's difficult to say. We shouldn't do cross-trial comparisons, as we seem to say pretty much every episode, and one of the presenters also said that. It's very funny that it's just something that keeps on coming up. But there are questions related to how to compare these two ligands. Probably not relevant in the near term, at least for us in Australia, but something to keep an eye on.
That's it, something to keep an eye on. I think maybe not prime time, but hopefully in the future another option, but also muddies the water.
Yeah, and it's always nice that engenders discussion, but does make it a bit difficult for clinical decision making. Josh, why don't you bring it home? We're staying in the radioligand area, but this is a study that is, geographically at least, quite close to our hearts.
That's it. I think the primary authors were based in our hometown of Melbourne, so that's pretty cool. It's nice to see some people up on the stage in the big smoke, so to speak.
Absolutely. So an Australian-led study, and we are very, very excited to see and proud to see people from the great nation of Australia up on those podiums.
That's exactly right. And so background-wise, lutetium PSMA, it's been proven in multiple trials to be beneficial in the metastatic castrate-resistant prostate cancer when you have a certain level of PSMA expression. And the question is really, what happens if you bring this forward? So there haven't been a lot of large randomized trials, haven't been any large randomized trials looking at lutetium PSMA done earlier in the, I guess, the plethora of how to sequence people and is it worthwhile and all these sorts of things. And so it's unknown. And if you go back to the prior charted trials, which are a great set of trials, they looked at treatment for metastatic hormone-sensitive prostate cancer. They found that ADT with docetaxel was the standard of care for de novo metastatic disease. That's come a long way with high volume, low volume. It's not as simple as you give docetaxel and you don't give docetaxel. And so the question was, given the addition of lutetium PSMA followed by docetaxel, would this enhance the outcome without increasing toxicity? And this is always the question. Do these treatments improve overall survival, but at what cost? And so participants had to have adenocarcinoma. It had to be less than 12 weeks from diagnosis. They had to have metastases on baseline CT and bone scan and a PSA of at least 10. They were then randomized to PSMA, and they were either on the experimental arm, where they were given 2 cycles of lutetium PSMA, followed by docetaxel for 6 cycles, or the control arm, where they were given docetaxel for 6 cycles with ADT. Questions are raised. Why only 2 cycles of lutetium? Well, it's very expensive. That's kind of the start of it, and it's all about rationalizing the use of lutetium in this context. The primary endpoints were that of an undetectable PSA at 48 weeks, and lots of secondary endpoints including progression-free survival, castrate resistance, radiographic progression-free survival, overall survival, and pain and quality of life. So 63 patients were in the experimental arm, 67 in the control arm, and recruitment happened from 2020 to 2023, somewhat hindered by that pesky COVID-19 virus. The median follow-up at present is 2.5 years, and the final accrual was 63 in the intervention and 67 in the control arm. Characteristics were well matched, multiple poor prognostic features with high T-stage, high volume disease. Moving to the results. So 41% of patients had an undetectable PSA at 48 weeks versus 16% in the docetaxel arm only, with an odds ratio of 3.88. This was significant. The undetectable PSA at any time point was 51% versus 32% with an odds ratio of 2.14. Again, significant and favoring the lutetium arm. And undetectable at 12 weeks, there was no difference between the groups. The secondary endpoints, metastases, or so radiographic progression-free survival was not reached in the combination arm versus 22 months in the docetaxel arm with a hazard ratio of 0.58. So that's 42% better. And quality of life and pain was similar between the two arms. There was quite a nice separation of the curve with the UpFrontPSMA Kaplan-Meier curves looking at time to event analysis with a hazard ratio of 0.60, again 40%, with the median time to event was I think it was 31 months in the combination versus 20 months in the control arm. And that's from months from randomization as well. And that's PSA progression-free survival. The other was free of castrate resistance. The combination arm was, again, better than that of docetaxel. As the adverse events are quite similar between the two, but it raises some really interesting and really pivotal questions. Is that, what do you do? Because this hasn't included androgen receptor signaling inhibitors. It's a very different world now, and this, I think, the inception of this trial was, I think, 6 years ago, they were saying. So an option, definitely, but also quite a costly option. And of course, you've got the trials like Arison's, which includes high volume disease, which is docetaxel and darolutamide and ADT. Does that work? There was more recent studies looking at just darolutamide and ADT in the metastatic hormone-sensitive prostate cancer. We do know that patients with high volume disease do have a better outcome with more intensification of their treatment. So really, really great study to kind of answer an unanswered question, but also then raises more questions about what do you do next.
Which for my mind is what a good study should do. And I think that, I wonder, and we spoke about this, I think it was on yesterday's episode, will there be a day where PSMA lutetium actually supplements or even eliminates docetaxel in the hormone-sensitive space? Because I think you'd be pushing it if you had what is essentially quad therapy in addition to all of the other medications that are needed to manage the side effects, where you have ADT and a novel anti-androgen, docetaxel, and PSMA. I think that'd be too toxic, but would you drop the docetaxel in favor of lutetium PSMA? Because you're not going to do it for any of the others. They're too intrinsic now in our practice.
I think it's my take on this, my humble take, Michael, is I think it's actually going to come down to optimal sequencing.
As well as availability. You mentioned that the expense of PSMA and lutetium, the making of the radioligand, it's quite an expensive, intensive process.
It is, and also, many countries will probably not have access to this for a while.
And docetaxel is dirt cheap now.
Yes, and does work, just has lots of toxicity associated with it.
Absolutely. So, thank you for listening to our very GU-heavy summary of ESMO Day 3. We promise there will be non-GU stuff at some point in the future. We don't quite know when. But join us tomorrow for our last regular ESMO episode, because we have, of course, the plenary special after that. We hope you're enjoying our ride. Josh and I are certainly enjoying being here and bringing all of this amazing research directly to your earlobes.
That's it, and we hope they thank you as well. Can't wait to talk to you tomorrow.
Bye. Thank you for listening to Oncology for the Inquisitive Mind. This episode was produced by ADC Productions, with the assistance of education grants from Pfizer, Gilead Pharmaceuticals, and Merck Pharmaceuticals. However, we do not allow creative or editorial control or even early previews of any content. They are hearing this episode alongside you for the very first time. If you like this episode, there's plenty more where that came from. Check out our website, inquisitiveonc.com, for all of our previous episodes, and make sure to subscribe to be the first to hear new content. If you'd like a particular topic covered on the show, or just want to chat, drop us a line on Twitter @inquisitiveonc, or by email on inquisitiveonc@gmail.com. Thanks for listening, and we'll see you next time.